Very nice session. Now going through another interactive session, that is driving through interventional pulmonology, a case-based discussion, which is a panel discussion. For that, I would like to invite Dr. Varun Patel, who is going to moderate this session. Sir is a consultant interventional pulmonologist, a senior pulmonologist at Ahmedabad, and a founder member of Swasan Chest Hospital. Also, I would like to invite Dr. Anand Patel, sir. Sir is a senior consultant pulmonologist at and associate professor at Gotri Medical College, Vadodara. Also, I would like to invite Dr. Jitendra Kotadia, sir. Sir is a consultant pulmonologist at Zydus Hospital, Ahmedabad. And also, I would like to invite Dr. Hiran Parikh, sir. Sir is working as a pulmonologist at Adicura Hospital. Thank you all. Also, I would like to invite Dr. Amit Dave, sir, as a pulmonologist. Yeah, thank you.
So the topic is journey through it's a case base of the IP. It's unrevealing the Odyssey, a journey through the ball to the healing. Uh, one lady which is coming to the OPD with the complaint of the cough is mostly dry in the nature with some expectoration, intermediate, and for 4 to 5 months, breathlessness of a grade 1 to on a grade 2, but last 1 month it's become a grade 3 of MMRC scale. The fever which is low grade and there is a one spike of 100 degree Fahrenheit over before the 5 days. Okay. So detailed history, there is a hypothyroidism and which is well controlled. TSH about the 5 with the ultroxin of 50. Cough with hemoptysis in 2021 and the one episode of the cough with the expectoration in 2029. Examination on OPD base is a normal, just only the decreased breath sound on the right side, and there is a no desaturation, but the mild tachypnea and tachycardia on exertion by the 3 floors climb up and down. So coming to the previous investigation, which is done in 2021 when the patient had a cough with the hemoptysis, the CT scan is on 2021. And one is episode of the cough with the expectoration with hospitalization in 2019. This was the X-ray which is available on that. So these are the larger view of CAT scan of HRCT view at the level of the inferior pulmonary vein. Investigation so far which is available at the time of OPD presentation in February 2023, when she had a cough with expectoration initial episode, there are eosinophilia periphery. After the treatment of the May, there is a 4%. In June, is again 33%. On day of presentation of the OPD is a 20%. There is a IgE which is also done. There is a more than 2,500. The chest X-ray which is available here is 2019. And the recent one, so I given to you for the larger picture here, 2019 X-ray, the February 23 and the July 23. So what could be your working diagnosis on base of the history and basic investigations?
Yes, ma'am, please.
We can never deny, ma'am. Please. Okay, ma'am. Any comment on chest X-ray? There is a no flinting shadows. The X-ray absolutely normal in 19.
Perhaps there is a collapse on the right side.
Right. So there is a collapse on the right lower lobe, probably started in the February.
Can be because of mucus plugging also.
Probably. And there is the more obvious you can see is the sharp in 2013 is the May month. Okay.
So can I comment on this? So there is no doubt, as the senior pulmonologist say, this is AVP to the point. But the take-home message is for the postgraduate. So our moderator asked working diagnosis. So what do you think? What we have to provide as a provisional diagnosis? So basically, if we look at the history, the data is pulmonary infiltrates since 2019. Patient has a cough with expectoration, one episode of hemoptysis. Gradually, lung X-ray, if you see, there is a mucus plugging because of right lower zone collapse. So working diagnosis should be peripheral eosinophilia with lung infiltrates. Okay, and then you have to identify which kind of lung disease, maybe a chronic eosinophilic lung disease, should be stratified and differential diagnosis should be given.
So patient is more symptomatic past 1 month and one episode of the fever that is 100 degree, and then patient also having a cough with expectoration. So on a X-ray you can see there is a complete collapse of the right lower lobe. The mediastinum shift towards a right side. So there is a no doubt there is a history of eosinophilia with a high Ig, suspicious ABPA, caused the mucus plugging. The patient present with the collapse of the lung, right? So that is the main
This
concern.
patient have a
To,
history of asthma and there was no wheezing at all.
no, there is a no history of asthma. There is a no history of breathlessness. Breathlessness that I saw you grade 1 today. But there is a no past any history of the wheezing, seasonal changes and etc.
According to the new ISAM criteria, now there is not a mandatory that patient should have asthma. Patient of COPD can also be suspected of ABPA. Patient with bronchiectasis can also be suspected of ABPA. Even cystic fibrosis can also be suspected of ABPA. Even if patient is not having any prior disease, if patient is having clinical radiological presentation compatible with ABPA, like expectoration of mucus plugs and fleeting opacity, or HAM, highly attenuated mucus on CT scan, then also you can suspect ABPA and you have to rule out the ABPA.
Right. So right now
The-
any
I think
relevance
in
of
this case the hypersensitivity to aspergillus was done, that IG, specific IgG.
that will come in later part. There is a first initial examination of the patient and we are starting with the working diagnosis, right? And then
So
we will just
working
narrow
diagnosis,
down.
you can put secondary infection also.
Yes, it can be.
Basically, as I
It can
said
be.
earlier,
You are
it
a
should
panelist,
be
you have to decide.
evaluated as a peripheral eosinophilia with lung infiltrates, and that you can differentiate whether it is an acute onset, whether it's chronic onset, and define the criteria. For peripheral eosinophilia, you need to rule out from the local disease to the chronic eosinophilic syndromes, and all chronic eosinophilic syndromes will compromise peripheral eosinophilia and lung eosinophilia. In the
In between the eosinophil was normal.
There is
Load
only
was
the one
normal,
it
four.
was
in a
normal.
May.
So
probably he
what the
might get
treatment was
steroid.
at the time, between this February to May?
Yeah. So when she was presented on February month, there was a cough with expectoration and fever episode, and then in May month, the treatment paper is not available, but probably she might receive a steroid, right? So that is the reason, because the 50%, 20%, 33% is a quite high eosinophilia. It's not just marginal high eosinophilia, and then you can differentiate. When you come to the absolute eosinophil count, it more in is 50%, right? Here, so the 4,000 something. By the second in the May, it's just about 240. So probably she might receive a steroid. The paper was missing there, but this was the one striking throughout to seeing this eosinophilia. But with this, you can find out with the ABPA the 51% of the eosinophilia, or it's just
Less
marginally
likely.
about 5 to 6, 7%.
Less likely. You have to rule out other causes also.
Yeah. So ABPA diagnosis criteria Anand has said.
So there are two major criteria and three minor criteria. According to new ISAM, earlier,
ISAM working diagnosis in 2013. There are the new criteria.
no, there are now
2024
2024 criteria,
Okay.
where they have reduced the cutoff level of IgE. It is now 500, less than 500. But the major criteria is serum specific aspergillus IgE. If it is not available, then you can go for the skin prick test also. So anyone of positive you can consider as positive. And another mandatory criteria is total IgE, which should be more than 500.
Previously was 1000.
Earlier it was 1000. And the minor criteria, there is a presence of eosinophilia, radiological opacity, and serum specific IgG for aspergillus. If you are suspecting ABPA, if you are suspecting ABPM, allergic bronchopulmonary mycosis, then there should be a serum specific IgG for
Aspergillus.
that particular fungus.
Fungus.
And for a skin prick test is more preferable for other for mycosis, ABPM. For ABPA, it's okay that serum specific IG is considered, but for other other mycosis, skin prick test can do. Any of the two criteria if present out of these three, then your diagnosis is confirmed. If total IG is less than 500, then also you can diagnose the patient if other criteria are fulfilled.
Got it. So now, next okay.
Just 1 minute. So, just wanted to highlight that many times we are seeing the similar type of patients, but as a routine practice, usually we send only sputum for gram stain culture sensitivity and AB and to rule out tuberculosis only. So, when we are suspecting that similar background, so we should send the sputum for fungal smear and fungal culture also. Otherwise, we will miss the diagnosis of ABP and other fungal infection. So that is possible in our scenarios. So we request that all of you should suspect the ABPA in similar case scenario and should send for sputum for smear also, as well as sputum for culture also.
Yeah, for ABPM, there is one more criteria of the sputum culture. 2 consecutive sputum culture should be positive for that fungus, or 1 ball culture should be positive for that fungus.
Like
for
NTM.
ABPM.
The 2 sputum culture or 1 ball culture. What probably a next investigation in this case?
Serum specific IgE for Aspergillus.
Okay. So Aspergillus fumigaceae specific IgE was 21.10, Niger was 42, antibody that is a 27.7, galactomannan is a 1.09, okay, I will let you know. Because on the first day, this will come later on a second, third day, so I kept in the behind. So as an intervention, that is a collapsed lung. I just start with
No, but that
video
CT
play
scan,
na
you didn't go for the CT scan. The CT scan was the earlier CT scan, na?
earlier cities.
So why not for this
It's a
time?
collapsed lung, so any pathology,
So for
any
collapse lung, you should also rule out the
fine.
malignancy.
So that was
also.
there on a 1st of June. 1st of July, I thought I should go for this, so I did that. Okay, so here the video is not working when we. Chala chala? Okay. એ પેલામાંથી ટ્રાન્સફર કર્યું છે ને એટલે એમાં થાય છે અત્યારે નીચેથી જો થાય તો ટ્રાન્સફર કરો. Okay, so there was a large, when we did the scoopy, there was a mucus plug which was removed, and there was a large fungus ball, right, which was evacuated through a scoopy with the Donia basket, and then patient was get admitted, and this was the treatment.
So Varun, can you play the video?
એટલે media file missing થાય છે પહેલામાંથી.
Yeah, yeah.
Yes. So that was there here. So after that, the patient was admitted, started with the parenteral antibiotic. As suspecting ABPA, we started with the itraconazole, systemic steroid, tropical bronchodilator with a nebulization form of the Saba-LABA and LAMA, mucolytic, expectoration, postural drainage, antipyretic, and supportive treatment. Okay. When the video is available, I will show you the video. Okay. So, what kind of the investigation you want to send from a bronchoscopic sample? When we do a bronchoscopy, what are the probable we'll do it?
So you had seen the fungus
so
ball.
this is a bronchoscopy video now, which is available with us. So there are the mucus plugging here. And this is a cavity.
It was a proper cavity, huh? It was beyond the subsequent bronchi.
Yeah. So it's through the bronchus we go. There is a large
So the
room.
cavity is a primary thing then.
Yeah.
Yeah.
It was evident on
So
CAT
you,
scan.
yeah, he told me that it can be happen in the bronchiectasis, cystic bronchiectasis. So
can
any
happen.
cavitary disease
So this is
may
a-
subsequently
this was
develop this
removed.
Aspergillus hypersensitivity.
Fine. the consistency of mucus plug, which is different than whatever the is evacuated.
Was it solid?
It could be dry.
It would be dry, so it's a mucus plug. We cannot
Fine.
never say label this as a fungal ball.
Okay.
So mucus
So we consider it as a mucus plug with the dilated and which is dry and become a mucolith.
So as Anand rightly said, when you have an HAM, in an HAM, the mucus plugs are going to be dry because it lies in the bronchus for a long time.
Got it.
It's like a broncolith,
It's a broncolith.
Usually.
Sorry.
You cannot say this is a fungal ball.
So it's a broncolith,
Exactly.
which is because of a dry things. So, right?
PG should not say that they are removing a fungal
Got
ball.
it.
Yeah.
So this was a culture report. The next day, which is available, it's a E. coli. The sensitive pattern is there. The next day, the X-ray was somewhat improved. Patient stabilized with bronchodilator and all the oral medication. The patient was discharged. Okay. So with this,
No, you had done the BAL, na? So you hadn't sent the fungus culture?
so there is on 3rd of July. This is a 24 hour after the bronchoscopy. So I have just only the bacteriological report available, not a fungal report.
Because if you are doing a bronchoscopy in a case of ABPA, then you should send the fungus culture.
So it was
Because
sent.
sometimes it happens that itraconazole may not work. If you are taking a sample, fungus culture and sensitivity should be sent.
But yeah, this I told you there was a primary cavitary disease. Cavity was there, and you find that, so you should send all the samples, including the
It's sent.
yeah,
All the
tuberculosis
samples
also.
are sent. I am going date by date.
Yeah.
So 1st of July,
Should be
that is
all
the
sample,
3rd of
including
July.
the tuberculosis. Huh? Yeah.
Everything was sent. But let it the report come. So the patient, it's a day by day report, right? It's not like that I kept everything and then we'll discuss in the case. It's a one by one. So on the 3rd of after
Varun,
24 hours,
CBNet comes within 24 hours.
after 24 hours, it report came.
Culture requires 2 to 3 days.
Fine. So how do you monitor this kind of the patient? And discharge
First we will
medication of your
diagnose
choice.
whether TB is there or not. The cavitary lesion is
Fine.
there.
So
So
we have to
CBNet, we
send a
will evaluate
CBNet.
for the BAL, CBNet and all.
Okay. Then next, apart from the TB, what are the medication you want to start in this patient?
So basically, let's round it up in very simple manner that bronchoscopy, once we have done BAL, we will send all infective parameters, including pyogenic culture, fungal culture, AFP culture, and gene expert. Apart from this, I feel कि BAL galactomannan, he has already showed the 5. So BAL galactomannan is also important. The consistency, as madam say, it's a bronchiolith. I would suggest that bronchiolith should also be investigate for the fungal culture. Now, once we have done all lineage of microbial culture, once we arrive, we come to know discharge medication. As of now, looking at the clinical scenario, if we consider this patient as a, we will label it as we have enough evidence of
ABPA.
ABPA. So we start with the antifungal along with anti-inflammatory therapy because Aspergillus specific Ig is high, total Ig is high, BAL galactomannan is also high. So all evidence. So we should not wait for the fungal culture to. So I think at least itraconazole or voriconazole as an antifungal, antibiotic according to pyogenic cultures, and we will wait for gene expert and AFB culture to arrive. Apart from that, we
Varun,
should not.
this investigation was with you before the scopy or after the scopy? After the scopy.
I think
Serum galactomannan, it's usually indicate the invasive aspergillosis.
True.
so BAL galactomannan is also
It's a
indicating.
high, it's
So
a
you-
3.5.35.
BAL galactomannan can be positive in commensal, but
So what
it is
is
not
the
a
cutoff value for the BAL and what is the cutoff value for serum galactomannan to be considered as a positive?
In both the case, it should be more than 1, I think. And BAL for is
for the
2.5.
serum galactomannan is a 0.5
5.
and for the BAL, the various study they make it the 1. So the
1,
1 is a
yes.
cutoff. The before more than 1, you can have
All
a
has
active
to be-
aspergillus.
Invasive aspergillus.
Yes, not invasive because invasive come on a serum. It's a BAL, if any fungus is a replicating fungus, you have a galactomannan high. So whether it's a replicating inside the body and that the antigen which go into the blood, you have a serum galactomannan, but it's a local, it's a high in a BAL. So you can say it's the presence of the aspergillus
In
fungus.
both scenario, we have invasive aspergillosis as of now. So we have to treat antifungal along with pyogenic culture.
Definitely. So
And
the
it should not
invasive as well as hypersensitive.
Yes.
ABPA with
So
invasive
we should not
aspergillus.
forget the anti-inflammatory or bronchodilator therapy along with mucolytic therapy.
Got it.
And with antibiotics, E. coli.
Right. So that was started with the treatment here. The gene
For
expert
E.
was
coli,
negative.
augmentin.
Pardon?
For E. coli, you give augmentin.
It was sensitive, I think.
It was sensitive.
Augmentin is a.
And then on after the 2 weeks, video. The patient got a call. The patient have a sudden onset of the breathlessness, and this was the CT scan when the patient came for a follow-up after 2 weeks.
ICD Narpani.
Okay. So the completely the right lung collapse. Video कर दो. And ICD was inserted. That is after 24 hours. Zigzag method to right and started with the applying a negative suction to see the expansion of the lung, and the X-ray in front of you, that is after the negative suction.
So negative suction was applied right from the beginning?
No.
After how many
After
days?
putting the X-ray, sorry, ICD, this continuous
Bubbling was
X-ray
there.
is bubbling, and then there is a partial expansion of the lung, right?
But there was bubbling on expiration only, I think.
Both. Persist.
No, during inspiration, it goes inside.
Next slide.
You are right. So immediately post ICD, at least you need to wait for 24 to 48 hours before you consider putting in a negative suction.
Definitely.
Because you need to allow the lung to expand first, and just if it's only PPF, then only put a negative suction.
Correct. So now your TB culture and fungal culture came. The fungal culture, there is a no growth, but your TB culture, the MOTT has arrived. Your gene expert was negative. I didn't show initially because I want
So
to
had you
start
done
a
sputum
discussion.
smear?
Pardon?
Sputum AFB smear.
No, I never sent a sputum. I
Why?
had sent a ball.
It's a basic first investigation.
Got it.
For
But
any
if you-
patient with
if
cough
you already-
with expectoration.
If you already done a bronchoscopy and you said a ball culture,
What I am trying to tell you is, you can pick up earlier if sputum smear is positive and CB net is negative, you can suspect the MOTT right from the beginning.
good. So that was there. So I want a discussion to be going on.
I think
So I put a culture
when
here.
He came to picture after so this everything complications happened after like collapse.
Yeah, it's a complication. So
After the
first day,
compli-
on the first, the patient is
So,
arrived to you.
but now
you
the-
have a working diagnosis. You narrate that. You start with the investigating patient to do a procedure, and then the complication happen. To managing a complication, then all the report is coming out. So that is a flow of the whatever that happened to the patient, and what we can do the best for the her.
Now the twist is that the MOTT. So whether the MOTT is a primary or ABP a primary, right?
Or maybe
it
a
should be a question.
coexist.
See, it was affecting the right middle lobe, and right middle lobe likely to be affected by this MOTT. It can cause the hypersensitivity. Right? The asymptomatic patient may you had told 3-4 years history. So I think considering this report, the MOTT is the primary things which was there already existing, which causing the gravitary lung disease in the lung, but not causing the constitutional symptoms. MOTT may be a cause similarly like bronchiectasis without any fibrobronchiectasis disease without any constitutional symptoms. So it actually may not require treat also, but the aspergillus hypersensitivity develops secondary to that cavitary lesion. That's what I consider.
Yeah. So there is a primary MOTT, secondary the fungal infection. Any other view?
Both the things can happen. ABPA first and MOTT also happen. As we have seen, 4% of that
Normal,
eosinophil, normal. So I think patient might have exposed to high dose of steroid, that the 51 eosinophil peripheral come down to 4 within just 2 weeks. That could not possible without high dose of steroid. So both possibility can occur. Now the thing is,
See, he is right. Both the possibility can happen. But see, the ABPA is not always a primary disease. There must be some underlying lung disease, fibrocavitary disease. Then it's supposed to come. So,
No,
if either it is asthma or some fibrocavities like cystic fibrosis.
So at present, the both possibilities there with the patient. We need to treat the patient, right?
Patient had a hemoptysis.
That is in 2021. Okay. So
What would be the next, right?
yeah. So what
So
to be a
I
next? So
think
we have
should
to
know the
treat
species,
both. We have to
which
treat
species
both.
it was.
We have to wait, and then again the patient is end up with the complication of BPF. Okay. Next.
It would be good differentiating tool if we do have a pre-existing spirometric data.
No.
Uh,
And after the patient has a collapsed lungs, we are not going to do for the spirometry at the same setting.
no, I am talking about in
Yeah,
20s
no, no.
or
Previously report is not available. Next. Okay. So we consider here both the infection are significant. We have to treat the aspergillus and we have to treat the MOTT. So which is antifungal to be, okay, let it be go, to be added here. And what to do with the BPF? So now the 3 days over the puncture at the BPF, there is a no lung expansion after even a negative suction. And meanwhile, we ask for a sensitivity of this, and the typing is there. So we come to the Mycobacterium abscesses. That is on 24th of July. And this is the sensitivity pattern. So does your itraconazole is a choice, and what are the MOTT choice here?
Yeah, definitely. This is a difficult case. Mycobacter abscesses need to be treated. That's your.
Cannot be treated. So as for the guideline, okay. So you have to treat with the one injectable, this aminoglycoside along with the clarithromycin, is a drug of the choice, right? Along with either you have a linezolide or clofazimide, etc. And on sensitivity pattern, you can add quinolone as well, okay? So what could be a drug of choice according to panel?
I think one injectable and two maybe fluoroquinolone and
So
linezolid.
the cornerstone is a macrolide, okay, and you
Yes.
have a ABPA, suspected invasive aspergillosis,
That is
and itraconazole can be a work with this.
No, better to use azithromycin than the clarithromycin because they both have an interaction with voriconazole and itraconazole.
Both.
So azithromycin is better choice than the clarithromycin.
Yeah, so avoid a complication, erythromycin is a better choice over the clarithromycin. Okay. So the started initially with the clarithromycin when you have a MOTT, and the sensitivity pattern is changed to the erythromycin. And voriconazole is a 6 milligram per kg was started. Video. ત્યાંથી ડાયરેક્ટ થઈ જવું જોઈએ. હા થઈ ગયો. So after 5-6 days of the negative suction trial, everything, expansion of the upper lobe, middle lobe is still collapsed, lower lobe is completely collapsed, and probably the lower lobe might have a connection with the pleural cavity, so the BPF there. So what could be a next approach? Whether we can wait with the antifungal treatment and MOTT treatment, or you go something beyond to out of the patient with this problem.
Depends on which guideline you follow, American guideline or British guideline. If you
You
follow the
say
British,
you are an Indian, and
so
the
in
patient
India
is in front of you.
we should wait for the at least 14 days.
14 days with this
Yes.
kind of the lung collapse.
Yes.
Okay. Dr. Jayendra?
Yes, definitely, we need to wait. See, both the disease, like fungal disease and this mycobacterial disease, any surgical intervention and suture decision would be a high risk. So we have to treat, at least I would say not 2 weeks, at least 4 to 6 weeks we need to treat with the antifungal and this thing and anti-mycobacterial agent. Okay.
Okay. Suppose there is you can see the middle lobe and lower lobe is nearly completely obliterated, obstructed or destroyed.
Definitely, things I will treat. This is the mycobacterial abscess. It is a persistent disease. Now a mycobacterial there is a mycobacterial. Some genetic test is available. Whether it would be eradicated or not.
Clarithromycin sensitive and macrolide
But
sensitive or not. Is
looking
based
at
on
the broader, the abscesses is there. The surgical option is a good choice. Yeah.
Okay.
So in this case, the lobectomy is the definitive
Definitely is
treatment.
the answer. Okay. So we wait for the 2 weeks.
I would like to little bit differ with you. See, if you see this complication arise just 2 weeks apart of normal chest X-ray, which you showed
That is on the 1st of
bronchoscopy.
July, and this is
This
of
is somewhere
30th,
around 2
30th
weeks.
of July, so 4
Yes.
weeks is gone.
So underlying lung was not that much destroyed. We can consider that.
So there is
just
a
a right
upper
middle
lobe
lobe.
is a normal, the lobar was collapsed. Okay.
This is what localized.
So
That is the
this
favoring
what's
factor for the
localized.
surgical intervention.
So
yeah.
if you go for surgical intervention and remove that particular part, that is okay. But still, I would suggest early intervention is better in the form of surgical to localize removal disease or try to open up
So
the
in a
lung.
panel-
If you remain this collapsed lung for more than 6 to 8 weeks, it will destroy it for sure. So you have to go ahead with the intervention.
So the two
Collapsed
people
lung
are
cannot be
two
destroyed
people,
by
two people
itself
are for
because
a
in
weight.
earlier era we used to collapse the lung to treat the tuberculosis.
So it is not a tuberculosis here. We are
Yeah,
we are doing a
used
collapse
to,
therapy.
there was a treatment of pneumothorax, artificial
Anand,
pneumothorax.
So I take a panel opinion. Two people are for the weight, and the one is for the surgery and the hearing. Early intervention, or you want to wait?
See, ideally, it's depend on the patient condition. If patient condition is stable, ideally we should wait for 2 weeks.
Okay.
And 2 weeks
So
we
the
should
three
give
people-
the trial of antibiotic, MOTT.
So it's
and
a 4 week
antifungal.
now.
And then if it is not expanding, then we should definitely
Got it.
try intervention.
Fine.
And,
So three people
doing
are for the weight. It's a 4 weeks right now. The lung is collapsed by 4 weeks. 1 week of the treatment of MOTT, right? The Amit is early intervention to salvage the lung. Okay. Next. Surgical intervention, as we discussed what to do, we go for the thoracoscopy BPS closure, either use a stapler, suturing, spigot or glue application, or a bilobectomy. Right? That was the option here. So I choose the less invasive, want to salvage the lung, because I go with the Amit, right, to salvage the lung and give her the best possible, the lung parenchyma to be salvaged to the patient. So you can see here there is a collapse of the lung with pus formation by pressing the lower lobe. You can see here there is a pus is coming out from the cavity. Okay. And there is a loss of adhesion. Some are vascular. So the adhesinolysis was done to mobilize the lung, to free it, to complete the dead space of the cavity, because the primary purpose is to occupy the pleural cavity by the expanding the lung. If the lung is not get expand, the cavity will fill up with the pus, right? So the BPF was too large and cannot be held with the forceps by a stapler. So that is the connection between the lung parenchyma and the pleural cavity. And what decide to be a suture. Okay, this is an absorbable suture. And the large BPF, which is converted to the small air leak, like because of the suture line. And we hope for a base to get lung expand, to irradiate the pleural cavity, and the sample, whatever we find out on that material, which was sent. The next day, this is the X-ray. The whole lung is expanded. Upper lobe touching to the costal pleura, the lower lobe, middle lobe as well. And you can see there is some, the bronchiectatic, or we can say the cystic shadows in the lower lobe. Okay. So, the patient, that is clarithromycin was changed to the azithromycin as with the panel. Voriconazole continue, amikacin was given. Moxifloxacin was given, not a clofazimide, based on the sensitivity pattern. With inhaled corticosteroid and the LABA was stopped, the patient was stable. I don't want to go steroid. The patient actually received a 0.5 milligram per kg of the steroid, that was stopped. Mucolytic, xanthin derivative, postal drainage, breathing exercise, everything was given to the patient. So that is on a 26th of July. And then after 2 days, when the patient reached to the home, the patient get complaint of the hallucination. And then we sent the electrolyte. Hyponatremia is there and hypokalemia is there. And because of the 5-6 days, we sent a trough level of the voriconazole. So any comment of hallucination and electrolyte imbalance in this patient? So the voriconazole can have a
Voriconazole level was
neurotoxicity, and
elevated.
that the hallucination is because of that, and voriconazole can produce a electrolyte imbalance, right? And there is the biphasic interaction between the clarithromycin and voriconazole, but already we had remove clarithromycin from the regimen, okay? The routine culture primary stain which was stained initially second time after the procedure was a negative at that time. This is after 2 weeks of a CT scan. Video please. कर दे दो. Some air in a cavity, pleural cavity. You can see the dilated bronchus of the middle lobe and lower lobe. The ICD well in the C2. The lung is completely expanded, and there is a no leak since 2 weeks, and ICD was removed. And this is a CT scan report with suggestion of significant regression of the right side pneumothorax with expansion of the previously collapsed lung. And there is a no air leak. ICD was removed. And after the 1 week of removal of the ICD, that is on 14th of August, the CT scan, X-ray was done. So there is a no, I can say, is a collapse or active disease here right now. So now, in this case, what is the duration of voriconazole you want to continue with this? Now, whether we have to continue with ABPA or we have to consider is invasive fungal infection where the BPF was happen, or the MOTT, as Jitendra says, is a primary culprit and structure damage lung which caused this problem.
We should consider ABPA because there is lots of evidence which supports the diagnosis of ABPA. As well as we should consider the invasive aspergillosis, and we should treat the MOTT also.
Okay, so everything you want, right? Make the patient happy and we also happy. Any other opinion?
We should treat the fungal infection along with MOTT, and 16 week is the guideline criteria. We have to
So
give
we continue with the 6 weeks,
months,
right? And
yeah,
for about MOTT,
we have to complete the course. Mycobacterium abscessum we have to treat in a phase manner. It will not go off easily.
so the 3
So
months
both
for injectable and the rest
injectable
continue
and-
with the oral medication.
yes.
Okay. So the patient came after 6 months, that is the 4th of the January 2024. Repeat CT scan, which was done. I just want to compare what happened to that bronchiectatic area. Is a ABPA, sorry, the inflammation area, and there was a plugging, so the scopy was done, which was the cavity as the mucolis was lysed, that was the dilated bronchus, which now confirmed through a scopy, and again there was a mucus plug. So the patient was not treated with the steroid for 6 months to considering as an invasive aspergillosis and MOTT both, right? So now at this phase, the fungal culture was negative, your MOTT culture is negative, okay? And this was the PFT, as you asked initially to look into that, but the patient is not of any treatment for the asthma, including the steroid for the ABPA, just only voriconazole, which was completed for 6 to 8 weeks, and MOTT treatment. So at this phase, there was the CT, there is a bronchoscopy finding, and this is the spirometry. Any change to regimen or anything to add with this?
We should add bronchodilator, small airway disease.
Right. So now you have a culture negative, both fungal and MOTT, right? Still we are continue with the MOTT treatment. Or should it continue is just colonizer or the something else?
No, it was not colonizer.
Okay.
We should complete the treatment and start with bronchodilator therapy, as FOT you are showing small airway disease.
But there is a restrictive pattern and without any bronchodilator reversibility, I think. So bronchodilator might not work. Or you can give a challenge treatment and evaluate again, do a spirometry.
Airway oscillometry is done and it is showing the small airway disease.
Yeah, so Amit is for you. That slide is for you, for oscillometry.
When spirometry parameters comes normal, we go for oscillometry and you can find the reversibility as well as small airway involvement.
Right. So with this, whether you treat it as a asthma, like it's a bronchodilator therapy,
Yes,
or
yes.
you just as a ABPA treatment therapy, Anand.
ABP.
ABPA.
So what do you want to like to give it right now?
Right now we can give a ICS plus LABA and we can again perform the test after 14 days of treatment.
Fine.
And we can see whether there is response or not.
So how long, like we had considered as an invasive aspergillus and we had given a 6 week of voriconazole. Again there is a mucus plugging. You want to add or antifungal right now? Itraconazole or voriconazole?
Yes, definitely.
Jitendra?
No, I would consider this is a ABP only, not an invasive aspergillus disease at all. This must be a ABPA. ABPA we need to monitor. See, in such cases, it is a highly sensitive case. See, he has a mycobacter abscess in between. So, though it is not an immunocompromised condition, so I would consider. But how long this mycobacter treatment has been stopped when you did this bronchoscopy, performed this bronchoscopy?
No, it was continued. Right
He was
now,
on the treatment.
she is on the treatment of MOTT treatment.
See, this patient.
So this is the culture is of 16 February. Right?
This
And
patient
we
highly
accept
likely
the
to have the relapse of the both the things. Okay, so you have to be a very cautious for the both the things.
Definitely.
When you are for using the steroid as well as the this thing.
So that is the one thing I did a bronchoscopy. Second
Yeah.
time, I want to make sure the none of the things should be there for the culture reports. And then, as you say, the high degree of suspicious we have to take in this patient.
Yeah, you can, the itraconazole is equally sufficient to prevent the relapse in the ABPA in long term if you
but
use
not
it.
for the invasive.
Invasive. So
So
you can
ABPA is
continue with, I
itraconazole.
think this patient should not be used now. It is a control, asthma part, asthma is not, asthma is basically preventing the asthma itself for the steroid anti-inflammatory agent you are using. Is this not a primary asthma case? You can use the itraconazole alone rather than using the steroid to prevention. And if the mycobacter abscess has been completed the treatment, you can stop it.
Okay, so we wind up this case right now. What is the last conclusion? Anything from a panelist, or should I give a last conclusion?
No, thank you very much. Nice case. I think we are running late. So organizer are telling us to wind up. We'll talk over the tea.
So just only the last thing. Whenever you see the normal chest X-ray in a short time and you have a complete collapse, do not label it a totally destroyed lung. Give it to expansion, and the pleural cavity, thoracic cavity should be filled by the lung. If you are failed to fill with the lung, it will fill by the pus, hydropneumothorax, and the complication of that. So anytime, do not hesitate to go for the intervention, early intervention involvement of surgeon. This all the procedure is done by me. Okay, so I have a more of I can say is the view. What is the inside? What is the outside? What is the patient? So the thing is that given a trial to the patient to lung to be expanded and fill the pleural cavity, that is the take-off message as early as possible. So in that case, you save the lung parenchyma and probably save the patient.
I think Varun, I think this kind of the intervention you only can do. If I ask this for this intervention to anyone to a thoracic surgeon, he will definitely deny. Definitely, nobody is ready to take the suture with this kind of the suppurative disease. Yeah, you are unlikely to stay. You success in this case. Higher risk of the failure is still there.
Yeah,
Okay.
it's always be there, but that is always to interaction with the patient, the best possible with the patient, discuss everything, and then we have to proceed. True. Thank you, Dr. Abhishek and KIPS team to give an opportunity for the discussion. Thank you.